Okay, hi everyone. My name is Meron Gebreyes. I'm a third-year medical student at UCI School of Medicine, and I'm part of their mission-based program, Leadership Education to Advance Diversity, African Black Communities. I'm here with Leo.
Hi everyone, my name is Leo. I'm a first-year medical student at UC San Diego School of Medicine. And today, me and Meron presenting our study titled Lack of Primary Care Physician Coverage and Overrepresentation of Black Patients and Non-Native English Speakers in Preventable ER Visits.
Yeah. So our project analyzes preventable ED visits at UCI Medical Center, and it was inspired by prior literature showing how preventable visits are associated with increased ED overcrowding and medical expenses, as well as weaker primary care physician-patient relationships. Literature also demonstrates that there are higher rates of non-urgent ED use in African, Black, and Caribbean populations. Our project's ultimate aim was to uncover any health disparities and factors that may be influencing the rate of preventable visits at UCIMC, with the hope that our data can inform future interventions that can be implemented to decrease the amount of preventable ED visits, increase patient access to healthcare, and improve the ED's quality of care. In this particular study, we evaluated the associations in perceived medical urgency, PCP coverage, and descriptive patient characteristics with non-urgent use of the ED. For our methods, we stratified a total of 340 adult ED patients into non-preventable and preventable ED visits based on triage level. So patients with an emergency severity index of 4 or 5 were classified as preventable, and those with an ESI of 1 through 3 were classified as non-preventable. Our study design is a cross-sectional exploratory study in an urban academic emergency department. We had patients complete a 30-item questionnaire in research electronic data capture, or REDCap, to assess descriptive information, self-perceived medical urgency, and PCP coverage. And then we did chi-square tests at a 5% significance level to examine these differences between race, native language, self-perceived medical urgency, and PCP coverage between preventable and non-preventable ED visits.
Perfect. Thank you, Meron. So I will now dive into the results of our study. So as you can see in table 1, we currently have 348 enrollments at the time of analysis, and then 188 of which belongs to the non-preventable ED visits, representing 54% of our sample, and 160 belongs to the preventable ED visits. And table 2 here is our main outcomes. As can be seen, there were more preventable visits among Black patients compared to non-Black patients. In addition, the preventable visit group had less native English speakers than the non-preventable group. Compared to patients in the non-preventable group, patients in the preventable group also are more likely to agree that they could have been seen safely and treated effectively by a PCP. And last but not least, fewer patients in the preventable group had a PCP that they can see regularly and make an appointment with compared to the patients in the non-preventable group. Hence, from our preliminary analysis, we can see that Black patients and non-native English speakers were overrepresented in the preventable ED visit group compared to the counterparts. As preventable ED visits are costly, these patients may be subject to increased financial and social burdens. Therefore, future research is needed to address the socioeconomic disparity. In addition, we see that patients in the preventable ED visit group were less likely to have a PCP, but yet they were more likely to have barriers to visit the PCP as well, despite the fact that they were more likely to agree that a PCP could manage their symptoms. So this potentially demonstrates that lack of access to a PCP may be associated with increase in preventable ED visits. Hence, increased access to a PCP may serve as an effective strategy to reduce the prevalence of preventable ED visits. Now, to conclude our presentation, we would like to kindly thank patients for their time spent taking our survey, and our physician mentors and the UCI MRAP program for the insightful discussion and help towards our project. Thank you everyone so much for their time listening to our presentation, and we will now open for questions.
In your second table here, I see that there is a section here relating to, I presume, patient belief that they could be treated by primary care providers. Was this this must have been a part of the questionnaire that I believe you all administered, and I'm just curious what yielded the NA in both of those categories.
Oh yes, yeah. For table 2, so yes, to answer your point. So this was part of the 30 questionnaire survey, and the reason why it was NA was because some patients, it was hard to justify within a table in terms of, because the thing is, patients who didn't have a PCP, they wouldn't have to answer this question. So it's hard within a table to accurately demonstrate that the accurate percentage of this response per se, but then we did run stats to compare the percentages and found that there was significant difference between the two groups.
Okay, excellent. And then in the questionnaire, I guess for determining the presence of a barrier to visiting a primary care provider, was that in the questionnaire, was that specifically listed as like job responsibilities or time conflicts?
Yeah, exactly.
Or was it patient perception of any sort of thing? Was it specific to those two criteria?
Yes, Meron,
Oh,
you can
sorry.
answer this.
No, yeah,
Right.
we had a question on there that was trying to assess for these barriers, and we listed a lot of the common ones that we've heard about or even read about in other papers, like my doctor's office is closed right now, my regular doctor told me to come in, or the ER is the closest provider, certain job responsibilities, I couldn't take time off from work, things like that were assessed.
Wonderful, thank you. Sorry.